evening, everyone. Thank you for tuning into tonight's Grand Rounds on Equity, Diversity, and Inclusion. My name is Anna Novatsky, and I'm an emergency physician practicing in Toronto. I'm also the former chair of the Women in EM Committee at CAEP. I will be moderating today's discussion along with Dr. Gillian Shepherd. Dr. Shepherd is the incoming chair of the WEM Committee, and she will be fielding questions from the audience in the background. Thanks, Gillian. I will start with a land acknowledgement, and I want to thank Dr. Evan Adams and Dr. Darlene Kitty for their help with this. To recognize the land is an expression of gratitude and appreciation to those whose territory we reside on, and a way of honoring the Indigenous people who have been living on these lands from time immemorial. It is important to understand the long-standing history that has brought us to reside on these, our homelands, and to seek to understand our place in our nation's history. Land acknowledgements are not solely about the past. Canada's treaties and ongoing relationship with Original peoples is a current and modern process, and we need to practice mindfulness of our present participation in our country's obligations to respectful coexistence, fairness, and equity for all. As our members gather tonight for this virtual National Grand Rounds, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and their traditional territories on which we work in emergency rooms across Canada. We recognize the many difficult challenges that Indigenous people face that impact their health and social well-being. We will self-reflect on what we must strive to learn and do more in helping Indigenous patients and their families in giving culturally safe care and contribute to reconciliation and anti-racism. I wish to acknowledge this land on which I currently live and work. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Churchill Island, and I'm grateful to have the opportunity to live and work on this land. When I first arrived in Canada many years ago from the bleak reality of communist Poland, I was truly impressed by the diversity of my new country. It seemed to me back then that Canada was a country of equal opportunity, no matter what race, religion, gender, or sexual orientation a person was. But that illusion quickly vanished. And as the years passed and my horizons widened, I started seeing more gaps in the system. And sadly, these gaps are very apparent in our healthcare system. In fact, they're most apparent in our EDs, which are the first and last resort for many of our patients. They are often their only safety net. Through our work with the Women in Emergency Medicine Committee, I have had the opportunity to really dive into the topic of equity as it relates to women in EM. But from the very beginning, I could see many parallels between the inequities that women in medicine face with those faced by other groups that have historically been marginalized. So today we wanted to take a look at the broader picture, that of equity, diversity, and inclusion in emergency medicine as a whole, as it pertains to our patients, to our training programs, and to us, emergency providers. The conversations we will have today will likely be uncomfortable for many of us, as they will nudge us to rethink the status quo if we haven't been thinking about that already. They will make us think of how we've unintentionally caused harm to our patients, maybe our colleagues, and maybe our trainees. And that's uncomfortable. So let's get comfortable with feeling uncomfortable. Today's discussion is really meant as a conversation starter, because really each of these topics deserves its own individual grand rounds, or three. Our speakers today will reflect the diversity of our patients, our trainees, and our providers. Let's listen to them to find out what we can do in our academic institutions and our EDs tomorrow to improve equity, diversity, and inclusion. I would like to start by introducing our speakers. Dr. Darlene Kitty is a family physician, and among many of her other jobs, she is also the director of the Indigenous program at the University of Ottawa Faculty of Medicine. She will discuss how emergency medicine in Canada can take some steps to address the inequities faced by our Indigenous communities. Dr. Meeta Patel and Dr. Jennifer Bryan are both colleagues and emergency physicians here in Toronto. And among many of the hats that they wear, Dr. Patel is the chair of the EMU conference, while Dr. Bryan is the lead of the upcoming CAEP 2021 panel on anti-racism and anti-colonialism in emergency medicine. They will discuss racism as it relates to emergency medicine in Canada. Dr. Nadia Premiani is an emergency physician and the chair of the recently formed LGBTQ+ committee at CAEP. She will tell us how we can improve emergency medicine care for the LGBTQ+ community. And last but not least, Mr. Matthew Williams is a 2017 Special Olympics World Games silver medalist and an advocate for individuals with physical and intellectual disabilities. He will discuss how health practitioners can improve their awareness of and address inclusivity for persons with disabilities. We will do a short Q&A session at the end of the talks. However, please don't hesitate to send in your questions and tweets throughout the hour. Though we might not be able to answer all of these questions during the course of today's discussion, we will do our best to post responses afterwards on the website. And now I will hand the podium over to Mr. Matthew Williams.
Good evening, everyone. I'm honored to speak to all of you and share how I got involved in Special Olympics, and through my involvement, discovered how important the need is to provide proper health care for people with intellectual disabilities. I was born with epilepsy and an intellectual disability. When I was 7 years old, I had major brain surgery to help try to control my seizures. Thankfully, the surgery was successful, and I have been seizure-free for over 15 years with the help of medication. I had grown up playing sports at an early age, and it was a big passion of mine. When I got older, I stopped playing sports, but because it had been too difficult to keep up with other kids because of my disability. Thankfully, though, when I was 13 years old, I found Special Olympics. Through my involvement in Special Olympics, I have had the opportunity to compete as an athlete at a local, provincial, national, and World Games competition level. I have also had the opportunity to speak around the world as an ambassador for Special Olympics. Through both of the experiences, I have got to see firsthand the great work that Special Olympics is doing for people with disabilities in healthcare. I unfortunately have also got to see and hear the many barriers people with intellectual disabilities face in getting access to proper healthcare. I would like to take a moment to share some of the reasons that people with intellectual disabilities face many barriers in receiving proper healthcare. Some of the reasons are because of stigma attached to having a disability, poverty or low income, not enough family support, healthcare providers refusing to treat individuals with an intellectual disability, not understanding how to communicate with a patient with a disability. People with disabilities are isolated, and also a lack of knowledge or resources provided to healthcare providers on how to best treat individuals with intellectual disabilities. Due to these reasons, people with intellectual disabilities are at a higher risk for health issues. I would like to share a few of the statistics on people with intellectual disabilities when they don't have access to proper healthcare. These statistics are from Special Olympics athletes in British Columbia screened from 2007 to 2016. 29% that went through the Healthy Athletes program failed a pure tone hearing test. 28% of the adults were overweight. 35% of adults were obese, while 32% of youth were obese. 23% had eye disease, and almost 7% had never had an eye exam. and 16% had untreated tooth decay, and 63% had gait abnormalities. These are really concerning statistics, and studies have shown that people with intellectual disabilities die 20 years younger than people without intellectual disabilities. Thankfully, the Special Olympics Healthy Athletes Program is working hard around the world to fix this issue. For those of you that haven't heard of Healthy Athletes is a service provided for Special Olympics athletes and individuals with intellectual disabilities. They provide free health screenings to address any health issues. They provide screenings for feet, eye, teeth, hearing, and a variety of other health services. As I mentioned earlier, I have benefited from the Special Olympics Healthy Athletes Program and have seen it do many amazing things for so many athletes around the world. I would like to share an incredible story with you. In 2015, I attended the Special Olympics World Summer Games in LA as part of Team Canada basketball. At the games, I heard a story about the Nigerian basketball team a day after our team had played them in competition. After our game the next day, the Nigerian basketball team attended the Healthy Athlete screening. Their whole team went through the Healthy Athletes hearing screening, and 7 of 10 members were tested, and I diagnosed that they needed hearing aids. Those members of the team were given hearing aids for free, as any athlete that goes through the Healthy Athlete screening program does not have to pay for the screening or pay for any of the items that are provided for them at the screening. Seeing the change in them was amazing. They could finally hear their coach's instructions, and he could verbally communicate with them instead of using sign language. They could hear the fans cheering in the stands, and at the end of the competition, their team went home with the silver medal. Special Olympics is not just changing our lives on the field, it's changing our lives off the field as well. But there's still much work to do. Here are a few ways that you can help support and make sure individuals with intellectual disabilities receive proper health care. You can have an individual with intellectual disabilities speak at your hospital or clinic to share how to better help them. You can volunteer at a Healthy Athletes in your local community. And if you have knowledge or experience in dealing with people with intellectual disabilities, educating others on how best to help treat and care for them. All these ways would help so much in making sure individuals with intellectual disabilities receive proper health care. In closing, thank you very much for letting me speak with all of you. And I hope by speaking to you today, you now believe that proper healthcare for individuals with intellectual disabilities is something that all of us deserve. Thank you very much.
Thank you, Matthew. Thank you so much for sharing your stories with us. Those were very, very touching stories, and I'm sure we can learn lots. But I want to bring up something that really has come to our attention, especially during COVID. I feel like accessibility has become an even greater barrier for individuals, especially with physical disabilities, but also intellectual disabilities. Many of the regular resources that they access may simply be unavailable because things are shut down. What are some small interventions that we can start in our emergency departments tomorrow to help address that?
I think ways to help that, I think is really using opening up the communication. I think also like through the social media and stuff, really being able to reach out, as you're saying, people with physical disability, um, um, might be a challenge to access that. So I think right now, really using social media and then technology as a way to answer those questions and maybe provide those services that right now are very difficult for them to access. So I think any way we can use technology to make sure that people are being educated and they're hearing the right things, and especially through this difficult time, I think is really important. So hopefully that answers your question.
Thanks. Yeah, thank you. And in fact, actually just brings to mind, some of our colleagues are starting to work on virtual ED care. So that might be something to actually help address that. Thanks so much, Matthew. All right, now over to Dr. Nadia Premiani. Thanks, Matt.
Good evening. Thank you, Anna, for the welcome. My name is Nadia Premiani. I am an emergency room physician here in Toronto at Mount Sinai Hospital. Both my parents were born in Italy and immigrated to Canada in the 1960s. I am a settler of the land of the Mississaugas of the Credit First Nation, Anishinaabe, and Haudenosaunee peoples. I have no disclosures that are financial. Excuse me. I do want to say that I am a cis white female. Though I identify within the queer community and identify as queer, I by no means represent the entire 2S LGBTQIA+ community. This is a topic that is near and dear to my heart, and I'm grateful to be able to be here with you tonight to start the conversation. There we go. These are some of my objectives. And so let's dive right in. Why are we talking about this? Gender identity and sexual orientation are key social determinants of health. We know that those in the 2S LGBTQIA+ community are more likely to have survived physical, sexual, and verbal abuse. They have higher rates of being underhoused, using substances, and having mental health diagnoses with higher suicide rates. Trans people experience some of the highest rates of violence in our society. Gender affirming and unbiased care leads to improved quality of life and psychological outcomes. Most of us trained in a time where there was very little education around the unique needs of the 2S LGBTQIA+ community. Those that do work within the community now have either educated themselves or learned along the way. We would never expect a patient with hyperglycemia to teach us about diabetes management. So it is not fair, and nor should we continue to expect our population that identifies within the 2S LGBTQIA+ population to teach us. When I speak to colleagues and when I read the literature about barriers to care for these patients, I have people who've told me that they feel uncomfortable asking about gender and sexuality. And as Anna mentioned initially, let's sit with that discomfort. Other physicians have said that they don't feel that sexuality or gender identity is relevant to the medical care. And a lot of people have told me, Nadia, I'm just afraid of saying the wrong thing. How many of you have walked into a room and said the wrong thing? I have. It can no longer be an excuse. Through qualitative research, we have heard from our patients that describe that discrimination, both anticipated and already experienced, is what discourages them primarily from seeking future care. Before I go on, we have to talk about semantics because words do matter. Scott Turner Schofield and Dr. Christy Overstreet both have great TED Talks about gender and ending gender. And they describe how traditionally we've been told that sex is equal to gender identity, which is equal or related to our sexuality. And this is not true. So let's talk about sex. Sex is what's been between our legs. It's what we're born with. It's our anatomy assigned to us at birth. Male, female, intersex. Gender is up here. It's how we identify. It's who we are. It's who we are and who we want to present ourselves as to the world. When our anatomy and our sex assigned at birth is congruent with our gender, that is the term we use is cisgender. Other terms you might have heard are man, woman, boy, girl, female, and male. Those are all very binary terms. They're at either end of the spectrum. Transgender refers to somebody whose sex assigned at birth and anatomy is incongruent with their gender identity. Some terms you might have heard are two-spirit, trans man, trans woman, transgender. There are many other genders, and I'll take away these words really quickly because it overwhelms people. Let's talk about sexuality. Sexuality is what's in our hearts. It's who we form relationships with, who we want to engage with and love and fall in love with. Some of the terms you might have heard are bisexual, heterosexual, homosexual, queer, gay, lesbian. And again, there are a variety of different sexualities. And so the big thing that we have to talk about now is the spectrum. So on either end, there are the binary genders and the binary sexualities. I don't have those written up here. And our patients can present anywhere along that spectrum. And we won't know where they identify unless we ask. What is your name? What pronoun would you like me to use? And the big thing that we need to remember is relevance. When is it relevant to ask about gender and sexuality? If a patient walks into the emergency room with a broken toe, I do not care about their sexual orientation. I do care about their gender. I do care about their pronoun that they want me to use so that I don't misgender them. If a trans man comes into the emergency room and has acute right lower quadrant pain, I do care if they have had any gender affirming surgeries or if they could be pregnant. One of the things that I'd like to dispel are some of the myths that people have. Primarily, these are myths that are based in heteronormative and cisnormative thinking. That is the assumption that everybody is cisgender and heterosexual. One of these myths is that trans people want to become a binary gender, or that every trans person wants to take hormones and undergo surgeries. Another myth is that every gay person wants to be in a relationship with the same-sex partner, or that every person who identifies within the 2S LGBTQIA+ community will use pronouns that are discordant with their anatomical sex. I encourage you to start changing the language that you are using. If you forget to ask a patient their pronoun, then please chart with the pronoun they and use the pronoun they until you can confirm which pronoun the patient prefers. Try to avoid heteronormative and cisnormative documentation. If a patient comes in that discloses their gender identity, I encourage you to use terms like AMAB and AFAB. Assigned male at birth, assigned female at birth, or anatomical male at birth, anatomical female at birth. Try using the word parent instead of mother and father, and try not to use terms like Mr., Mrs., and Miss unless the patient tells you otherwise. Let's move on to hear what our patients have told us through the literature that leads to positive interactions and what we can do to continue these positive interactions. The first is language, and I think I've talked a lot about that. The one thing that I want to add to all of this is intake forms. Speak to those who are able to change your forms for you to allow an area where patients could document their gender, their name, and their pronoun. That is not just male and female. Demonstrate experience of working with the 2S LGBTQIA+ community. If a patient discloses their gender that is non-conforming and non-binary, respond with an affirming or neutral reaction, not with shock and awe. And when sexual diversity is not acknowledged by bathroom signs, by intake forms, by open-ended questions and gender-neutral questioning, it tells our patients that we are aware of their unique needs. Our patients have told us when their interactions with us have been more negative, hurtful language, misgendering, and using incorrect names and pronouns, having trans curiosity and asking irrelevant questions and doing irrelevant examinations that are not related to why the patient is there, pathologizing gender differences, and displaying discomfort and unfamiliarity with the 2S LGBTQIA+ population. They gave us some resources and tips as to what they would like to see from us to move forward. They would like us to have a Trans 101, one patient said in a research study, which is essential basic information about gender identity, sex, and the major health concerns faced by the 2S LGBTQIA+ community. They would like us to involve patients within the community in our curriculum development and our policy development. They don't want us to continue to have them to teach us about their concerns. And remember that not all issues that are related to their gender identity and sexuality when they come into the emergency room or come to see you in their office. Check in with your own biases, assumptions, and judgments. For those of you in leadership, I encourage you to take a look at this article in Forbes about how to cultivate a workplace culture that inspires diversity and inclusion. So what are the 5 things that I want you to take away from tonight? Use a name and pronoun, and the only way that we know what that is by asking our patient. Try with just one person, just one. The next patient that you see, ask them their pronoun. And with time, it will become the norm and much more comfortable. Try to take away unnecessary gendering. Tomorrow, go to your workplace and change the bathroom signs to gender neutral signs. Explain the relevance of your questions and examinations. Be an ally and an advocate for those around you. And I want to make sure that I don't expect each and every one of you to do this all on your own. Find the champion that's in your department that's already doing this. Ask them for their opinions. Ask how you can help. For some resources, you can check out the World Professional Association for Transgender Health Standards of Care and the Canadian Centre for Gender and Sexual Diversity websites. I leave you with this quote from Audre Lorde. "It is not our differences that divide us. It is our inability to recognize, accept, and celebrate those differences." Thank you.
Thank you, Nadia. One of your points really resonated with me, and it's the one that we shouldn't be expecting our patients to teach us about language, about their health concerns. When I was a resident, there certainly was no formal training that was dedicated to addressing emergency care for the LGBTQ+ community. However, one of the EDs where I trained was well known in the community, and patients felt safe going there. Patients felt like it was a place where they could be and they would be understood. Unfortunately, they did not have great experiences elsewhere. So that's one point, but I have a question for you, and I'm going to sort of, do a little bit of a preamble. So during COVID, all gatherings, including Pride Week, were canceled, and one of my wonderful colleagues, Dr. Claire Heslop, shout out to Claire, came up with a great idea of how our department could celebrate despite that. And so she ended up procuring and distributing surgical caps with rainbow flags. And many of us continue to wear these surgical caps now, months later. And I've actually had a number of patients say to me, wow, this makes me feel accepted. This makes me feel at home here in this department. And so it was such a small intervention, but it had such good positive impact. Are there other small interventions that you are aware of that could help break the ice with the LGBTQ patients who may have had poor ED experiences elsewhere?
So it's a great question. I think, lanyards, you can have a little pin that has the pride flag. We have buttons at Sinai that say that I'm an ally with the updated pride flag. I just want to be very careful by having a pride flag or having a rainbow doesn't mean anything to the patient if you misgender and are unaware of their health needs. Absolutely. And do all of those things that cause negative interaction. So it's one thing to say that you're aware and that you know that it's Pride Month and that you support the 2S LGBTQIA+ community, but be very mindful that your entire ED, from the unit clerks to the service assistants to the porters, all have to be educated and on the same page to back up the fact that you're wearing that symbol. So I think it's a great idea. I think that anything that you can do, if you feel comfortable and feel that you are knowledgeable about their needs.
Thank you. That's a great point. Thanks so much.
Thank you very much.
All right, let us now move on to Dr. Jennifer Bryan, Dr. Meeta Patel. Go ahead.
Thank you so much, Anna. Meeta and I are both emergency physicians living in what is now known as Toronto. We're going to be focusing on racism in emergency medicine in Canada. I grew up as a mixed Black settler in Newfoundland. My mother's family is originally from Ireland and England. My father was from Barbados and immigrated to Canada in the 1970s.
And good evening, my name is Meeta Patel. and I'm a settler and descendant of family born in India, migrating to East Africa, England, and finally Canada in the 1970s.
Anti-Black racism is as much a Canadian issue as it is an American one. While we're fortunate to have many Black leaders past and present to guide this work, as noted by the UN in their 2016 report, being Black in Canada also means being overrepresented in the criminal justice and child welfare systems, having higher rates of unemployment and lower pay than white counterparts.
Race, race is a social construct. There are no racially mediated biological differences in disease risk factors. Racism, not race, is a social determinant of health. Dr. Ibram Kendi, a Boston University professor and anti-racist researcher, discusses how racist ideas underlie the suggestion that there is something intrinsically wrong with Black people that leads to poor health outcomes. Instead, there are racist health policies that lead to racial injustices and inequities. Anti-racist policies are needed to achieve racial equity and justice. Racism is a public health crisis. Racism leading to health inequities and death is an emergency.
It can be difficult for those of us in a caring profession to acknowledge our role in perpetuating systemic racism. Dr. Dominic Shelton, emergency physician and co-founder of the Black Physicians Association of Ontario, says, being altruistic and having biases aren't mutually exclusive. We all have biases. The question is whether we bring them into our interactions with others. Interpersonal racism refers to racism at the individual level. For example, during my training, a speaker described an assailant as big, intimidating, and most of all, Black, expressing bias that being Black is intrinsically threatening. Systemic racism is the collective perpetuation of racism and occurs through education practices, hiring, and promotion. It can be invisible to those not disadvantaged by it. In the absence of systemic racism, the many experienced staff who attended the lecture I mentioned would have publicly challenged the speaker. Instead, they didn't, and everyday racism as the norm was perpetuated. Unless we accept that there's a problem systemically, we'll deny our role in it. Anti-Black racism impacts health directly and creates barriers to physician advancement and medical education. One example comes from the experiences of patients with sickle cell disease. While sickle cell affects people of all races, most of those affected in Canada are Black. Serena Thompson describes the impact of stigma. She talks about putting on nice clothes, making sure her hair is done, because she knows she needs to get the acceptance of the ED team before we'll treat her pain. Her experiences are shared by countless other patients who also encounter stereotypes about Black patients, pain, and believability. It's easy to discount patient experiences of poor care and attribute them to wait times or overcrowding, but I challenge you to consider why we are so quick to dismiss patient concerns about racial bias. None of us as emergency physicians start a shift saying that we want patients to feel unwelcome in our EDs or to leave not feeling cared for, but that's exactly what's happening at both the individual and population level.
Unfortunately, Canada isn't faring differently from the US or UK when it comes to the overrepresentation of racialized groups contracting COVID-19. In Toronto, racialized groups are overrepresented in their share of COVID-19 cases. Specifically, as of mid-September, Black people accounted for 23% of the city's cases, despite making up only 9% of the city's population. There is significant underrepresentation from the white and East Asian groups, as you can see here as well. Reasons accounting for this overrepresentation include the fact that there is inequitable access to healthcare and social services, as well as the negative encounters with the healthcare system. There is reduced access to stable housing and education. There are harmful consequences resulting from the chronic exposure to toxic social, physical, and economic environments. Finally, there is a higher proportion of racialized groups and women in lower paying jobs considered essential services, such as janitorial staff and personal care and support workers. The ability to work from home, reducing exposure to COVID-19, is a privilege that many people do not have.
Black physicians also experience the impact of anti-Black racism. The Black Physicians Association of Ontario found that Black physicians experienced discrimination from peers, senior colleagues, and patients. They reported offensive remarks and exclusion from the Old Boys Club in promotion and hiring practices. One encouraging finding is that there were positive experiences of collegiality between Black colleagues and stronger relationships with Black patients. Black physicians are also subject to the minority tax. These are the extra responsibilities placed on faculty from underrepresented groups to achieve diversity. Increasing attention being placed on anti-racism brings hope for meaningful change, but also increases the unpaid work asked of physicians who are Black, Indigenous, and people of color. This work can take the form of increased burden for achieving equity goals, increased responsibility for mentorship and educating allies, in addition to physicians' own clinical work and other activities that are more likely to be recognized by their hospitals and universities as worthy for advancement. Finding ways of recognizing this work financially and academically can ease the burden.
There's no data on the racial demographics of ED physicians in Canada, but there is data on all physicians in Ontario demonstrating that Black physicians are grossly underrepresented. As emergency physicians, we are in a unique position to serve our increasingly diverse patient population. The underrepresentation of minority clinicians has been identified as a contributing factor in health disparities in the US. Look around you at your place of work. Is there representation in race? How about indigeneity, gender, disability, sexual orientation or sexual identity? Literature demonstrates increasing the number of racialized and minoritized physicians in the emergency department can increase cultural sensitivity to the patients we treat.
We're seeing an encouraging increase in representation in Canadian medical schools. In 2016, over 250 students began med school at U of T. Despite being in one of the most diverse cities in the world with a nearly 10% Black population, U of T admitted only one Black medical student. Getting into med school is difficult, but for Black, Indigenous, and people of color, there are additional barriers. Initiatives like the Community of Support and Black and Indigenous student application programs have demonstrated that underrepresentation can be addressed at least in part by providing access to work networks, to admissions information and guidance. It's important to note that students admitted through the BSAP and ISAP meet the same rigorous academic standards as other students. In contrast with 4 years ago, this year, 24 Black med students were admitted to U of T, 60 across Canada.
Mentorship matters, and it contributes to the professional growth and development of individuals. Mentors do not have to be racialized for racialized individuals to advance and succeed. Do I wish I had someone to seek counsel from who understood some of the challenges I faced as one of the few racialized women during my training and earlier in my career? Absolutely, yes. To have experiences validated, guidance on how to navigate areas where power imbalances exist would have been uplifting. Mentoring individuals who are underrepresented in medicine and creating roles where they can be successful will help strengthen the workforce, and it'll lead to more creativity and ideas that do translate to innovation. I'm a faculty mentor in the Diversity Mentorship Program at U of T's Faculty of Medicine. This program connects medical students and first-year residents from underrepresented, racialized, minoritized groups with faculty mentors. I'm hopeful that these types of programs will lead to a brighter and more inclusive future ahead.
We've been asked to suggest 3 next steps. The first we'd like you to consider is about reflexivity, looking critically at our own biases and getting educated. We're excellent learners in emergency medicine. The same lifelong learning skills that you brought to pick up point of care ultrasound, for example, are the ones you need now if you're going to take steps towards becoming anti-racist. We've included a number of good starting points throughout this talk and encourage you to learn more. The Canadian text, Anti-Racist Healthcare Practice by McGibbon and Ottawa is another excellent place to begin.
The second point is about representation. Representation is power. We need to actively walk the talk of equity, diversity, and inclusion, mentor and invite those who are not already at the table in order to create a richer, more welcoming and accepting culture for the betterment of emergency medicine in Canada.
The final take-home point is that getting beyond the status quo means developing meaningful and respectful community partnerships that are more than tokenism. There's a proverb that says, if you want to go fast, go alone. But if you want to go far, go together. We need to acknowledge the role of systemic racism in patient care, physician advancement, and education, and to support Black, Indigenous, and people of color as we work towards solutions. Thank you very much.
Thank you.
Thank you, Jennifer and Mita. So you both discussed how representation matters, and we have spoken about this offline multiple times. We spoke about that in the context of speakers at conferences, but also in training programs in medicine. From our work with the WEM committee, I know that a paucity of senior women mentors for women in EM has a trickle-down effect on the women who are seeking mentorship. The situation becomes, I'm sure, even more dire when you're a person of color looking for a senior mentor in a leadership position, as you mentioned, Mita. And we know that mentorship is important, but the fewer members of a group there are, the harder it is for potential mentees to find mentors. So when we talk about representation, what can CAEP do tomorrow as our national organization to improve representation?
Well, I think I'll start by saying I don't think that the situation becomes dire when you're a person of color looking for a mentor. I think there are certain unearned privileges that racialized or minoritized groups do not have, and that they're grossly underrepresented in leadership. I think as emergency physicians, and using our social context as positions of power, we can all do our part in mentoring, sponsoring, and coaching those who may have unearned disadvantages.
And maybe I can follow up a bit on Mita's point there as well, and that going back to why it is that diversifying leadership is important, right? So it's not only the right thing to do, but we know that it leads to more effective decision-making, and it's really the antidote to groupthink. The first step is to start by asking who's not at the table. So if you say there's no one qualified, then you need to cast a wider net. You need to look at involving groups like the Indigenous Physicians Association of Canada, the BPAO, and other professional associations across Canada. You need to look at your leadership supply chain, just like Mita's spoken about, to work on mentorship and sponsorship of potential future leaders. And then finally, we need to put some money and some accountability behind the anti-racism statements. I think that we are all very hopeful and excited to see Dr. Kirsten Johnson coming into the role as the new CAEP president. She's someone who's very supportive of addressing equity issues, and we're all very much looking forward to seeing what the coming years are going to bring. Thank you.
Thank you both. All right, I will hand the podium over now to Dr. Darlene Kitty. Go ahead, Darlene.
Wajah, which means hello in Cree. I'm glad to be here tonight to share my Indigenous perspective with my colleagues here. First of all, I'm Cree and a family physician working in Chisasibi in Northern Quebec, and as well as my academic hat at the University of Ottawa. So I'm going to speak on cultural safety and reconciliation in the ER. These are the objectives, as you know, for tonight's talks. And I basically will start with barriers and work my way backwards. Also, I have no disclosures. So first we'll start with some definitions. Cultural safety, which according to the First Nations Health Authority in BC, is an outcome based on respectful engagement that recognizes and addresses the power imbalances inherent in the healthcare system. This means the Indigenous patient and healthcare professional, or namely emergency physicians, have to be equal partners in the healthcare. And cultural safety results in an environment free of racism and discrimination where Indigenous patients will feel safe when receiving healthcare. And along those lines, we have to look at cultural humility. So why is it important to learn about cultural safety and Indigenous health and social issues? It's because we need to self-reflect to understand our own biases, plus that of the healthcare system, and maintain respectful process and relationships with Indigenous patients based on mutual trust. We must acknowledge that we are learners, and we have to consider this when it comes to appreciating the experiences of Indigenous patients. On another note, the Truth and Reconciliation Commission of Canada released its report in 2015 and had 94 calls to action. But before that, we need to recognize how reconciliation is defined. So here it looks at how we review what's happened with Indigenous people over the centuries. We must be aware of the past, acknowledge what harm has been done, atone for the causes, namely the residential school system, and take action to change behavior. The report of the TRC Commission mentions that it's not only the Indigenous peoples that must be involved with this, but also all Canadians. So it's important to move forward together. I mentioned the 94 calls to action. Well, there were 7 specifically in health. And these are 4 of those 7 that are relevant to medical education and health services by physicians and other health professionals. So these namely call for increasing the number of Indigenous health professionals. And in our case, emergency physicians would be very good. Looking at retention and also providing cultural competency training for all health professionals, as well as having our medical nursing schools teach about Indigenous health and social issues, including the residential school experience, the UN Declaration of Rights of Indigenous people. And the main theme here, of course, with the TRC Commission report was the impact of the residential schools in Canada, which still lingers and is still hurting our current generations. So you can see here some pictures of some of the residential schools in Canada. In the top right, Kamloops, BC, one of the most notorious schools. The bottom left, Fort Capel, Saskatchewan. Ironically, there's teepees outside the gates of the residential school property where some of the families may have stayed to try and see their children. And one of the most famous pictures is the bottom right, where you can see a young boy in his First Nations regalia, his traditional wear. And later, through the years in residential school, he is assimilated to look like a white person. So this is some just pictures of our Canadian history, such a tragic chapter. It's important to learn about these things, just as someone would learning about the Holocaust. No matter where you go in Canada, there's probably been a residential school nearby. There are over 130 residential schools, but also day schools, boarding schools, and industrial schools scattered across Canada. You can see at the blue arrow, that's where I work in Chisasibi. A lot of schools were more located in the west of Canada, but certainly in the major urban centers, there was residential school located nearby. So wherever you are working, it's important to think about this, find out more information, and learn from Indigenous peoples in your city or town to start appreciating the dark history. Why is that important? Well, Indigenous people have the poorest health status in Canada. Many communities are impoverished. There is many mental health and social problems. And largely this is linked to the residential school experiences and the multi-generational trauma. One important thing I believe is that there is still a lack of knowledge of healthcare professionals, administrators, and politicians of these impacts of residential schools and other social factors that are obvious today in the Indigenous communities. And I strongly believe it's a social, moral, and ethical responsibility of emerged physicians, nurses, other health professionals to learn about this, understand, and help to reduce health inequities and systemic racism. So what are some barriers to culturally safe care? I mentioned a lack of knowledge, but also not only just about Indigenous people in general, but also more specifics about the culture of the Indigenous group in your area, their traditions, their beliefs, values, and attitudes. You know, how important is their traditions? Likely very important. Connection to the land, their history of the community, their political issues like treaty rights, so many things that you could learn from. Language is an important barrier that must be accommodated as much as possible. Using an interpreter, for example, when helping an elder who is unilingual. Sometimes explaining to them about their medical condition can be very overwhelming. So don't use big words if you can help it. Simple things like that, and asking them, you know, do you have any questions? What can I help you to understand? There are administrative barriers, and sometimes this relates to the power imbalance, the attitude of the professional working with that Indigenous patient. How about funding? You know, how is the patient funded to come to an urban center to have further treatment? What are their treaty rights? So those are things that you can find out more. Access to healthcare. You know, how are they transported? How do they come from their community to the emerge? Maybe they're living in the city, you know, maybe they can't afford a bus pass. What about access to specialist care, diagnostic tests, and further treatments? What about non-insured health benefits? You know, many First Nations are covered under this, but when they leave the reserve or their community, they are no longer covered. So sometimes, you know, getting their prescriptions filled can be a challenge. So that's another barrier. Some patients live off reserve, or Indigenous, well, First Nations patients live on reserves according to their treaties, but we prefer not to call them reserves, we call them communities. You must remember they not only live in remote and rural areas, but also urban. There are urban populations as well. And of course, the big barrier, the R word, racism. So whatever you may call it, stereotyping, prejudice, assumptions, that's the big barrier. And you've heard Dr. Brian talk about that, and Dr. Patel. We'll come back to that. So in helping Indigenous patients, it's important to gain more knowledge and respect for their culture and traditions, learn more about their social problems, especially about the residential school experience and multi-generational trauma. It's important to understand why they have a higher risk of certain problems like depression, suicide, substance use, and other social problems. What's behind those problems? You know, maybe they were abused as a child because of residential school. There could be many, many reasons why. So it's important to understand and not just make an assumption that all Indigenous people are suicidal or do drugs or drink alcohol. It's by far not that. Think of your own values, beliefs, and attitudes. Because many people still think this is what Indigenous people look like. First Nations, Inuit, Métis on the streets, downtown Montreal, Vancouver East Side, downtown Regina or Saskatoon. You know, this is unfortunately what people think. I hope you recognize this man. This is Brian Sinclair. He was a middle-aged man living in Winnipeg, and was a frequent flyer to the emergency department because of alcohol and substance use. He lost his legs to hypothermia and suffered some cognitive deficits because of his substance use. And one night he went to emergency after being sent in from a family doctor to have a Foley catheter changed because of his neurogenic bladder and having probable UTI. He waited 34 hours for care in that emerge before he died. He was found dead in his wheelchair, having never been triaged. And 4 bystanders attempted to get help for him. They told the security guard, they told the triage nurse, but he never received care, progressively got sick, and probably died of urosepsis. His family largely believes that he died of racism, and I believe that's probably true. There was an inquiry into his death, and all they looked at was the flow of patients through the emergency department from the waiting room to the internal area. This is unacceptable. And his death still echoes throughout Indigenous circles, and now more so when we talk about anti-racism. And lately you've heard the story of Joyce Echaquan, a Atikamekw woman who was receiving care in Joliet Hospital in Quebec. And she unfortunately died after hearing racist remarks from her nurses and other caregivers that were attending to her. And she progressively got sick quickly and died in the emergency room. This is unacceptable. Very tragic and deplorable treatment given to her. And if it weren't for her courage to videotape this, we would have never known this would happen. And unfortunately, there is many Brian Sinclair's and many Joyce Echaquan's stories across Canada. So we have to stop this. We need to talk more about systemic racism, and this is only a drop in the bucket. There needs to be more time dedicated, more motivation for emergency department staff to learn and take action. So there's many different types of racism. Sometimes somebody says something that may be unintentional, but when an Indigenous patient is receiving this information, they perceive it differently and it could be offensive. So it's important to learn about race, culture, racism, and think about it yourself. Discuss it. It can be hard to talk about, but it has to happen for change to happen. We must recognize that Indigenous people have suffered because of historic and current policies, and this affects their health and social well-being. We have a disproportionate burden of disease and less access to healthcare services, especially depending on the geography of their communities. So again, it's important to learn about their cultures, demographics, and health status, and also include with that learning about their traditions, including traditional medicines and healing. It's important for your communication to be appropriate for the level of the patient. Sometimes it helps to listen and be patient and be silent. Also recognize that not all Indigenous patients are traditional. Some people live in rural and remote areas, live out on the land part of the year, go fishing and hunting, but others are integrated into cities, working and going to school and doing well. And sometimes there's people who are really struggling and living on the streets. So it's very diverse across First Nations, Inuit, and Métis populations, and it's important to appreciate that. And once again, it's important to avoid stereotyping, making assumptions, and prejudice and racism. Residential schools, racism, and culturally unsafe care negatively impact the health status and outcomes of Indigenous people. And I'm counting on you to learn more about this and contribute to improving this. So I leave you with a true story that happened when I was doing an emergency rotation. I was finishing with a chart and moving on to my next patient when a middle-aged First Nations man was brought into the emergency on a stretcher with his arms restrained to the bed rails. He was agitated and thrashing about, moving his legs, looking sweaty, disheveled. He was previously known to this emerge with alcohol intoxications. So as I was putting down the chart, instead of going to get the next chart, I went to him and I went to tell him, to calm down. I touched his arm and looked him in the eye and said, "I'm Dr. Kitty. I'd like to help you. If we take these off, will you stay calm?" And he looked at me, and maybe it's because I'm Cree, recognized me as a First Nations woman. And so he says, yes. And as we were doing that and making him comfortable on the stretcher, he's told me he's a residential school survivor. So I looked at him in the eyes and I said, yes, I understand. For me, I understand because both my parents went to residential school and I'm an intergenerational survivor. So he calmed down and I started to assess him quickly. And what he told me was he had chest pain, shortness of breath. We took his vitals, used hypotensive, tachycardic, respirations were 32, his SAT was 88%, no fever, had a few crackles on quick auscultation of his chest, and ECG showed rapid AFib. The nurses put some oxygen on and started intravenous right away. I get emotional telling this story because clearly someone who's previously known to the ER for alcohol, looking all agitated and thrashing about, could have been misinterpreted for being drunk again. But he wasn't. He had a cardiac emergency. Unstable AFib. He was shocked, and luckily it only took one shock, and he quickly stabilized in normal sinus rhythm. And I helped to admit him to the ward. What happened during that case surprised me because the attending physician I worked with heard him say he was a residential school survivor. And he seen me quickly do my assessment. The nurses put the IV oxygen on, took his vitals. And after, when I was writing up the case for admission, he told me that. What is residential schools? I was so happy he asked that question because it was important for him to understand. And he hadn't learned what was an emergency physician who really should have known. This particular emergency sees a lot of Indigenous patients, and that man could have died there from unstable AFib. So it's important for everyone to know what affects Indigenous people's health and social well-being. And there's many things that are negative, but some things are positive too. Culture, traditions, that gives people strength. Being in their communities, having people appreciate what they've been through, that can get them through a medical problem and get on to better health. So quickly, 3 things. 3 recommendations: start learning about Indigenous cultures, history, health and social issues, including the residential schools, anti-racism. One thing I really strongly believe is that there should be mandatory cultural safety training for all emergency departments. Well, in an ideal world, all health professionals, and maybe someday we'll get there. This not only includes physicians and trainees, but also other health professionals. Because remember, no matter where you go or work, you will see and treat Indigenous patients. We need to train more Indigenous physicians and other health professionals to work in the emerge and in other areas, such as clinics, where we help Indigenous patients. And it's important, obviously, to become an ally and learn more about inclusion, social justice, human rights, and advocacy for Indigenous patients, families, and communities. And it's important that you make a commitment yourself or in your emergency department to learn more, do more, to contribute to reconciliation and strive for culturally safe care. Thank you. Miigwech.
Thank you so much, Darlene. Thank you for sharing those difficult stories. And I think it is important that we are discussing this today. As emergency physicians, we have the privilege of seeing people in their most vulnerable states, and we have the moral responsibility to ensure that all of our patients receive the best possible care, regardless of where they come from, what they look like, who they love, or what they believe in. I know, Darlene, you have done a lot of work in both representing and trying to improve representation of the Indigenous community in healthcare through education and mentorship of young Indigenous people. In the interim, though, I wonder if having local Indigenous champions, Indigenous physicians, nurses, or patient partners in the ERs to promote the health of Indigenous patients, has that been trialed anywhere in Canada that you are aware of?
Well, I know in some of my travels to conferences and meetings that some hospitals are hiring like Indigenous patient navigators to support patients in the emerge, or when they're at an oncology appointment, or when there's a crisis affecting the family that the patient needs the navigator to get them through that. Some hospitals are bringing elders in to visit Indigenous patients, where I have some of my patients go further south for like surgery or CAT scan. There is a Cree patient navigator that supports a patient and goes to them to connect to see if they need help. Sometimes there's traditional healers visiting some of the emergency departments, or even just some of the inpatient wards, so we need to figure out, wherever your emergency department is there someone in that area in a local Indigenous health clinic that can connect with your emergency department and say volunteer a few days per month to meet Indigenous patients or just be on call. So there's a lot of possibilities.
Thank you so much. I know we're running against the clock, but I do want to ask one more question. Maybe I'll post this one for Nadia and Jennifer. What advice do you have for the white male who'd like to demonstrate that he's an anti-racist ally?
So I think that's a fantastic question, Anna, and I hope that there are a lot of allies who are asking themselves that question tonight after our talks. So the first thing that I would suggest is, just like we included in our talk about education, right? We are at a point in our history where there is a big upswelling of interest in anti-racism and anti-colonialism work. There are so many opportunities for education, so many fantastic talks that are being offered, so many interesting publications. So the first thing that I would suggest is educate yourself and look at what people have been talking about. Just like Nadia included in her talk, we don't look to our patients with diabetes to teach us about diabetes. The same idea in your work as an ally. Start off by educating yourself. There's lots of opportunities out there. And so I hope that people undertake that challenge.
Thank you so much. All right, unfortunately, that's all the time we have for today. But we do hope that we will be able to continue these discussions, maybe at another subsequent grand rounds. Each of these topics is so so deep, and there are so many issues to discuss that this is really a shame that we have to finish now. But we do hope that you will take some of these ideas back to your emergency departments, to your academic institutions, back to your leadership, and reflect on how even a small change can really make a big difference for your patients and for your colleagues, as well as your trainees. I want to thank CAEP's leadership for providing us with this forum for discussion. And this discussion doesn't end here. This was just the start of a conversation. Thank you so much to all of our speakers today for their time and for sharing their experiences and their expertise with us today. And how will CAEP continue this conversation? CAEP is actually in the midst of planning the 2021 Academic Symposium on Equity, Diversity, and Inclusion. And the leads of all the panels will be looking to all of you for input. So please get involved. And finally, I wanted to invite you all to join us for the next CAEP Grand Rounds, which will take place on November 17th, and it is entitled Zooming Through the Best of CGEM's Just the Facts. Thank you so much, everybody. Good night from Toronto.